Dear friends, this is revision total knee replacement surgery where this initial surgery was done 20 years before. Here we are using, you can see that sleeve with the stem at the tibial surface. On the tibial side, the cementing is done only on the surface of the tibia. Sleeve is now going to be implanted at the tibial side, and it is an uncemented sleeve, and the stem cement is only on the surface, and the implanting is done up to the level which was marked with the trial implants. This is a platform of the tibia we would have planned with the trial implants, and cement is being filled at the area between the bone and the implant base plate. Now we will be implanting the femur. Again, here also there is a defect and the condyles are deficient. Here we are using the augment at the femoral side. Also sleeve. The sleeve is uncemented and the stem is uncemented, cement on the surface. Rotation of the femoral component is very important when we are using the sleeve. We have to make sure that rotation is properly fixed, because this sleeve and the femoral component rotation has to be marked and fixed before we implant it. This will be same as what we did with the trial implantation, and again up to the extent which we had put the trial, same level we have to hit the sleeve. We should use some kind of measurement with the scale or with a guide. Otherwise, if we continue to hit, there might be chances of shaft cracks in the metaphyseal already thinned area. This insert we are using the trial one. This is 12.5. We will be then checking the MCL stability in extension and flexion. We are intending to use 15 mm. You can see slight laxity of MCL with a 12.5. So actual implantation with the 15 mm of insert is already planned. Now we will be using 15 mm. You can see that the patient is very obese. This is 110 kg female. This is a semi-constrained, so the ligamentous integrity is going to work with this kind of implants. Varus valgus constraint is only semi, meaning 100% absolute stability is not given if MCL is absent or LCL is absent. So we have to make sure MCL is functioning most importantly whenever we are using this kind of implants. Otherwise, we have to switch to hinge kind of implants if MCL is not intact. Here we are now using 15 mm insert, and then I am just demonstrating the integrity of MCL. In spite of so much defect in the femur and so much defect in the tibia, the MCL is now nicely visible, and it is giving stability to the patient, stability to the knee. You can see I am now doing medial lateral movements, and patellar tracking is very good because we have now fixed the femoral implant at the rotation which was marked with the trial. So all these things we have to take into consideration when we are doing the revision total knee replacement. So now this completes the implantation. Nice flexion extension. In spite of so much obesity, we have been able to fix the semi-constraint. Thank you for watching this video.